Welcome to this module on renal and urinary emergencies. We'll start with a brief review of renal anatomy, followed by discussing two of the most common urinary emergencies you'll see in the ER, blocked CATs and acute kidney injury. Let's get started. Welcome to the Master Course on Urgent Care, brought to you by Cruza. We'll start off with some renal anatomy review. I know you're going to have to dig a little deep for this one. The kidney is a bean-shaped organ that sits in the retroperitoneal cavity of the abdomen. Working from the outside in, it consists of a cortex, or outer region, the medulla, or central region, which is then further broken down into the outer medulla and the inner medulla, with the inner medulla containing the papilla at its innermost tip. The papilla empties urine into the minor and then major calyx. At the most basic level, urine is made throughout the renal cortex and renal medulla and empties through the papilla into the minor calyx, then the major calyx, and into the innermost part of the kidney, the renal pelvis. Urine then flows out of the renal pelvis and into the ureter, and then from the ureter, it travels down to the urinary bladder. The kidney is also surrounded by a soft tissue capsule. As the kidney filters all of the blood in the body several times a day, it has a very impressive blood supply. It initially receives about 25% of cardiac output, and blood travels through the renal artery into a diffuse, extensive network of capillary beds throughout the renal cortex, where it's filtered by small nephrons. After filtration, it travels through the remainder of the capillary beds, emptying into the venous blood supply via the renal vein. There are two main capillary beds. The first is the glomerular bed, which has a high hydrostatic pressure of around 60 millimeters of mercury and allows for rapid filtration of the blood. The second is the peritubular bed, which has a lower hydrostatic pressure of only around 13 millimeters of mercury, and allows for rapid reabsorption of the fluid and electrolytes initially lost during the rapid filtration process. The nephron is the functional unit of the kidney, and this is where urine filtration occurs. Cats contain about 200,000 nephrons and dogs about 400,000 nephrons. Each one of these nephrons is broken down into a glomerulus, or a tuft of capillaries, where blood is filtered through a negatively charged basement membrane, and tubules travel out of the glomerulus and through the renal cortex and medulla. It is at the level of these tubules that fluid and electrolytes are either reabsorbed or secreted based on the patient's body's needs. Due to the complex nature of renal blood filtration and fluid reabsorption and secretion, a detailed breakdown of how urine is made is outside the scope of this master course. However, if you're interested in the kidneys, I highly recommend taking some time to go back through the detailed anatomy and physiology of the kidneys, as they are truly fascinating and complex organs responsible for so much of what makes the body function. They're actually my favorite organ. A great resource for reading about the kidneys is Vander's Renal Physiology textbook. Now that we have briefly reviewed renal anatomy, let's talk about a couple of the most common urinary emergencies you will see. A brief review of definitions associated with urgent care urinary cases will help us along the way. See if you can match up the following words with the correct definition on the screen. If you guess the following answers, you're doing great. Plaquuria means frequent abnormal urinations throughout the day. Dysuria means painful or difficult urination. Hematuria means blood in the urine, and stranguria means slow and painful urination or straining to pass urine. These are all common signs that a patient might present through the ER for. So let's think about this in the context of a specific case. Binks is a 4-year-old male-neutered domestic shorthair who presents through the ER for a 48-hour history of straining and vocalizing in the litter box at home. The last time the owner saw urine in the litter box was approximately 12 to 14 hours ago. There is no evidence of blood, but the owner does use a clay clumping litter, so we can't rule it out completely. The owner states that Binks does have a history of occasionally straining to urinate, most often associated with new events happening in the house, like visitors or spring cleaning. However, usually these episodes resolve on their own, so he's never been seen by his veterinarian for them. On your primary survey, Binks is quiet, alert, and responsive with a heart rate of about 160 beats per minute, no audible murmur, an adequate pulse quality, mild increased respiratory rate at around 32 to 36 breaths per minute, and normal effort. You proceed with your secondary survey and palpate Binks's abdomen. Upon palpation, you appreciate that Binks is painful and vocalizes, and the urinary bladder palpates large and firm. The remainder of your examination is unremarkable. What is your primary differential for this case? So this is a pretty common presentation that you'll see in a lot of urgent cares and ERs throughout the United States. The primary differential in this case is urethral obstruction. However, we don't stop there. We need to figure out why this kitty cat is obstructed in the first place. Does he have an infection with pyuria, crystalluria with an accumulation of crystals creating a blockage in the urethra, sterile cystitis with white blood cells or inflammatory cells creating a blockage, a urolith, or possible urethral trauma? What diagnostics would you pursue for Binks at this time, and what stabilizing steps do we need to take for him? Let's start with diagnostics. Any suspected block cat coming through the hospital should ideally have full blood work performed, including a complete blood count, a serum chemistry panel, electrolyte evaluation, urinalysis, and a lateral abdominal radiograph. However, it is not uncommon for owners of block cats to have financial constraints. If that's the case, the minimal recommended diagnostics for a patient like Binks would be a PCV total protein, a renal panel to evaluate blood urea nitrogen and creatinine levels, electrolyte evaluation to look for changes in potassium in particular, and a urinalysis. Let's say Binks's owners have no financial constraints and we get to do all of the recommended diagnostics for him. His CBC shows a mild non-regenerative anemia and a leukocytosis with a white blood cell count of 20,000 and a neutrophilia of 18,000 with suspect bands. Our chemistry panel shows that he is azotemic. His creatinine is 3.2, with the normal range being about 0.8 to 2.4. His BUN is 64, with the normal range of being about 16 to 36, and his chemistry panel otherwise looks normal. On his electrolytes, his potassium is elevated at 6.8. He has a normal sodium of 155 and a normal chloride. On his urinalysis, we appreciate that he has too numerous to count red blood cells and white blood cells, with extracellular and intracellular bacteria and struvite crystals present. A lateral radiograph shows no evidence of stones in the urethra or the urinary bladder. Given that struvite and calcium oxalate are the most common stones found in cats, and both of these are radio-opaque, meaning they should show up on x-rays, this helps to successfully rule out the presence of a stone causing the urethral obstruction. We can now expand our problem list from urethral obstruction alone to urethral obstruction with a urinary tract infection and struvite crystalluria, azotemia, and hyperkalemia. We also have some mild anemia. So how are we going to treat Binks? The first step is correcting any dehydration deficits he may have prior to sedating him for a urinary catheter placement. It can be counterintuitive to give patients with urethral obstructions intravenous fluids. However, it is very important at this time that we correct any dehydration deficits and potentially any electrolyte disturbances for Binks. He's also azotemic and has mild borderline bradycardia. IV fluids are very helpful in this situation. We would ideally use a balanced crystalloid. As we know that Binks has a urinary tract infection, we also want to start him on an antibiotic for source control at this time. Ideally, you would hold urine from the initial urine sample taken for the urinalysis prior to starting antibiotics, and that way you can send that urine out for urine culture. Once we feel he is adequately hydrated, we can proceed with a sedated urinary catheterization. There are many options for sedation. A relatively safe protocol would include butorphanol or buprenorphine with a benzodiazepine for pre-medication, followed by an anesthetic agent like propofol or alfaxolone. It's my general experience that if owners do not have financial constraints, urinary catheterization with the patient intubated and on an inhaled anesthetic is not only the safest choice for the patient, but it also makes catheterization easier. Titrating drugs like alfaxolone and propofol can be used. However, you have increased risk of not being able to control your airway if your patient is not intubated. Possible risks include urethral trauma and urethral tear during catheter placement. Regardless of how safe we are, how minimal the obstruction was, I always warn owners that this is a possibility, because if it happens, you want to make sure that they know that it was something that could have happened regardless of how you performed your procedure. Next, we want to select a urinary catheter type. The most ideal urinary catheter is soft to limit urethral irritation and make the patient more comfortable. It has minimal risk of reactivity and is resistant to biofilm formation. Common materials available for urethrostomy include plastic, red rubber, latex, siliconized elastomer or Teflon-coated latex, hydrogel-coated latex, and pure silicone. These are listed on the screen in order of decreasing urethral reactivity, increasing biofilm resistance, and increasing the duration of time that it can be indwelling in the patient. Thankfully, Kruza offers some great options for us to choose from. Kruza urinary catheters are atraumatic and biocompatible. The catheter has a rigidity and lubricious surface, which ensures easy catheterization. The suturing plate is soft with suturing holes, and the syringe fittings work with Luralock syringes. Once the urinary catheter is placed and attached to a sterile collection unit in our friend Binks, we want to recover him from sedation and recheck an electrolyte panel to evaluate for persistent hyperkalemia or elevated potassium. Elevated potassium is common in cats due to obstruction and decreased altered filtration at the level of the kidney. It can oftentimes be corrected with intravenous fluid therapy alone. However, uncorrected potassium can lead to cardiac dysfunction, manifesting in the form of bradyarrhythmias. In the case of severe, persistent hyperkalemia leading to bradycardia, correction with medications such as calcium gluconate and/or insulin administration may be necessary. Please refer to a textbook on critical care medicine and pharmacology for further information, including dosages and mechanism of action of these medications. Binks should be maintained in the hospital on intravenous fluid therapy and antibiotics. The urinary catheter is kept in place until the azotemia has resolved, with weaning the IV fluids down. So you want to make sure that your creatinine is staying low even after you've taken him off of fluids or gotten fluids to a very low rate, and your urine output is consistently matching your input. Something that can happen in these patients following resolution of the obstruction is medullary washout, where the tubules are not concentrating appropriately, and it takes them a few days to catch back up. That's where measuring your ins and outs is very, very important, because it can help you to make sure that your patient is not becoming dehydrated and helps you monitor for medullary function returning back to normal. At the time of discharge, a discussion of feline cystitis and management, including a dietary change and appropriately managing water intake and stress at home, would be recommended for Binks. In the ER, you're also going to see dogs with urinary obstructions. The diagnostic workup and initial treatment is very similar to that with cats, with alterations being made dependent upon the findings on your blood work. Male dogs also don't have to be sedated as significantly as cats do in order for the urethral catheter to be placed. Female dogs should still be heavily sedated or intubated for urinary catheter placement. Struvite stones and calcium oxalate stones are also the most common stones in dogs. However, dogs are much more likely to also have radiolucent stone formation, such as urate and cystine stones. This means that they won't show up on x-rays, and it would be very important in a patient, if you don't see a stone on radiographs and you're concerned for an obstruction, to pursue a focused abdominal ultrasound of the urinary tract, including kidneys, ureters, urinary bladder, and proximal urethra. If the dog is large enough, you may also be able to see stones within the intrapelvic urethra or at the level of the prostate. The other reason to do a focused ultrasound examination on dogs if no stone is seen on x-rays, particularly male dogs, is to rule out the presence of prostatitis, prostatomegaly, and prostatic abscess formation. Let's shift our focus a little bit and talk about acute kidney injury management in the hospital and some of the more common toxins that can cause acute kidney injury in cats and dogs. Acute kidney injury refers to an abrupt change in renal function that leads to retention of uremic toxins and dysregulation of fluid electrolyte and acid-base balance. It is a spectrum of disease that ranges from non-detectable subcellular damage to fulminant failure. There are three classic categories we think of with acute kidney injury. The first is hemodynamic or pre-renal. It means there is decreased renal perfusion or excessive vasoconstriction of the vessels at the level of the kidney. It can be rapidly reversible if the inciting cause is eliminated right away. The second is renal parenchymal injury or intrinsic injury. Prolonged ischemia or lack of blood flow contributes to renal parenchymal injury with other causes including infectious disease, toxins, or systemic diseases with a renal manifestation. The inciting cause of injury must be removed or reversed. There is a long list of potential nephrotoxic agents and includes medications like aminoglycosides, cephalosporins, and sulfonamides, antifungal agents like amphotericin B, chemotherapeutics, antiviral medications, antiprotozoal drugs, and other miscellaneous medications including acetaminophen, allopurinol, ACE inhibitors, diuretics, and NSAIDs. There are also non-therapeutic agents like bee venom, calcium antagonists, grapes, lilies, snake venom, and vitamin D containing rodenticides, which can all cause acute kidney injury at the level of the kidney itself. Last, we have post-renal injury, which is secondary to obstruction or diversion of urine flow with prolonged obstruction leading to intrinsic injury. For our friend Binks that we talked about previously, if we had not removed his urethral obstruction, he would have had that type of acute kidney injury. Urethral obstructions, bilateral ureteral obstructions, urethral or ureteral trauma, and neoplasia are all causes of post-renal acute kidney injury. The pathophysiology of acute kidney injury is multifactorial and typically divided into 5 main phases. The first is the insult phase, and that's when your first renal injury happens. The second is your initiation phase. You have cellular or subcellular damage that starts to occur and may not necessarily be biochemically evident, so you might not see it on blood work at all. Intervention can prevent progression to more severe disease if it's rapid. The next phase is extension. This is when you'll see your biochemical and clinical derangements. Your fourth phase is maintenance. This is when cell death and regeneration occur simultaneously with the length of recovery based on the balance of these two processes. Your removal of your inciting cause may not alter the existing damage at this point. And then fifth and finally, we have recovery. We get an improvement in glomerular filtration rate and tubular function. This period can last weeks to months. When we think about the presentation of patients with acute kidney injury, they're often listless, have vomiting, diarrhea, and anorexia, but they can come in for a variety of different signs or just following suspected toxin ingestion, and you have to monitor for the presence or development of acute kidney injury. From a diagnostic perspective, the standard laboratory diagnostic tests, including CBC, PCV total protein, complete chemistry panel, and urinalysis, are recommended. In addition to these, acid-base evaluation and lactate evaluation can be very useful for establishing the severity of your patient's clinical picture and helping you to make decisions on how you want to treat that patient. It is not uncommon for these patients to have severe metabolic acidosis or hyperlactatemia associated with their acute kidney injury. It's very important to grab urine prior to starting any sort of additional treatments and IV fluids in these patients with suspected acute kidney injury. You also want to examine the urine as quickly as possible after collection to avoid artifactual changes. Patients with acute kidney injury are often hyposthenuric with a USG of less than 1007. However, the presence of isostenuria with a USG of 1007 to 1015 can be seen with cases of intrinsic failure. Urine sediment can be very helpful in determining the presence of bacteria, red and white blood cells, and cast formation that's suggestive of tubular injury, urinary tract infections, and possible pyelonephritis or infection at the level of the kidney itself, not just in the urinary bladder. You might also see crystal formations, particularly in cases of ethylene glycol toxicity, where calcium oxalate crystals develop in large numbers. The urine dipstick can show the presence of glucose, protein, bilirubin, and hemoglobin, depending on the underlying cause of failure. On a complete blood count for a patient with AKI, you may see hemoconcentration from dehydration, or alternatively, you may see pre-regenerative or non-regenerative anemia from large volume gastrointestinal blood loss associated with uremic ulcerations. Platelet counts can be normal or low in patients with acute kidney injury. It is also important to note that uremia can lead to coagulopathies, so if you suspect your patient is bleeding, consider testing coagulation times like your prothrombin and activated partial thromboplastin times. Treatment of your patient with azotemia is going to depend on the cause and duration of acute kidney injury. We'll talk a little bit about IRIS staging, which allows us to grade the level of AKI that our patients are exhibiting. Acute kidney injury is confirmed by the presence of an increase of creatinine by 0.3 milligrams per deciliter within a 48-hour period of time, even if that increase occurs within a normal range. So grade 1 is a creatinine of less than 1.6. Grade 2 is a creatinine of 1.7 to 2.5. Grade 3 is a creatinine of 2.6 to 5. Grade 4, creatinine 5.1 to 10, and grade 5, a creatinine of greater than 10. There are also subgrades of acute kidney injury, including oliguric and non-oliguric, and those patients that require renal replacement therapies. An additional diagnostic test to consider in patients with acute kidney injury is an abdominal radiograph, and it can be helpful in showing the presence of stones inside of the kidneys or in the urinary bladder. It can also show stones within the ureters and the urethra. However, it may not give you a very good picture of what is structurally happening at the level of the kidneys. Therefore, an abdominal ultrasound is strongly recommended. Depending on the origin of kidney injury, additional specialty testing like antegrade pyelography, MRI of the kidneys, and measurement of glomerular filtration rate, or GFR, could be considered. Depending on patient history, you can also consider testing for specific diseases such as infectious diseases of leptospirosis and tick-borne diseases, or potentially testing for toxins like ethylene glycol. If there is no known toxin ingestion, a urine culture should be sent out on any patient with suspected acute kidney injury, urinary tract infection, and pyelonephritis. The treatment for acute kidney injury is truly dependent upon the underlying disease process that's present. These patients should be admitted to the hospital with careful monitoring, including frequent weight evaluation, ideally urinary catheterization in order to measure urine output, and evaluation for the development of oliguria or anuria. We should also do frequent blood pressure monitoring and frequent evaluation of our electrolytes. In true cases of acute kidney injury, the prognosis unfortunately is guarded. A recent meta-analysis of outcomes in dogs and cats with AKI showed a 45% mortality rate in dogs and a 53.1% mortality rate in cats. Another retrospective study of dogs showed that approximately 60% of surviving dogs had some degree of chronic kidney disease, and only 40% recovered normal renal function. Obviously, this is very dependent on the cause of the acute kidney injury and patient progression in hospital. It is very important to have an upfront and honest conversation with owners anytime you admit one of these patients to the hospital. This includes setting realistic financial investment expectations, discussing the severity of the clinical disease, and reviewing that the prognosis is guarded if active severe acute kidney injury is present. Obviously, these patients are also going to be on intravenous fluids in the hospital. However, we never know how they're going to respond to IV fluid therapy. That's part of the reason we have a urinary catheter in place. If they have severe acute kidney injury with oliguria, meaning decreased urine production, or anuria, meaning absence of urine production, or anuria, meaning absence of urine production, we find ourselves in a situation where these patients are going to accumulate fluid within their body, their weight is going to increase, they may develop swelling peripherally, and they're also going to have more severe electrolyte derangements. These are all associated with a more guarded prognosis. These patients start to become candidates for renal replacement therapy. So it's important to know where your local hospital is that does things like hemodialysis. We can also consider hemodialysis in patients that have certain toxin ingestions. These include things like high levels of NSAID ingestions or ethylene glycol ingestion if it is caught early enough. Again, I highly encourage you to know where the nearest facility is to you that can do renal replacement therapies, so that way you can make sure that you're giving your patients with acute kidney injury the best possible chance of survival in the long run. That concludes our module on renal emergencies. Please move on to the next module when you're ready. Thank you.